Hello, everyone. This is the RHC Billing Test Lunch and Learn. I am Mark Lynn with Healthcare Business Specialist, and let's go ahead and get started because we have a lot to cover today. Not going to go through this section as much as I normally do because by now this is the 8th webinar we've done in the last 3 weeks. So you should be knowing us relatively well now, what our team does. We hope that this series of webinars has been very helpful to you in learning about rural health clinics and learning about the things that you need to do before the end of the year and to get your billing up and going correctly for next year, and also getting your cost report prepared with the highest possible cost per visit. I think that's been a big part of us trying to push these webinars out before the end of the year. So those are all of our services that we provide. Here's the Facebook exchange. So please, if you've not signed up for that, we have 4,700 members. We want to see this thing grow to 5,000 maybe by the end of this year. So let's get this thing growing. And if you would join that, that would be great if you haven't already. All of our materials here is on our website at ruralhealthclinic.com. I have a lot of people that will email me after this is over and ask me for the materials. And I have put everything on the homepage for these webinars. So if you just scroll down a little bit, you're going to find the recording of Charles's James, Amanda Dennison's, Patty Harper's presentations. Those will be there. The slides will be there as well. You just have to slide down, just scroll down a little bit and you will find all of that. And that is directly on our homepage, the first page that you go to. For today, I have put your handouts over here. There's the billing test. There's the presentation. Don't look at the presentation because you're going to cheat if you do that because you're going to see the answers. But the billing test is there. There's 20 questions, and then there is an answer key, and I think I put the answer key on there too. So don't be peeking. And hopefully this will work out really well. This may be the Titanic and this thing goes down, but Paige Chambers will be here. She's going to run the polls. You're not going to have a lot of time to answer these because we have 20 questions. So probably maybe 15 seconds, maybe 30 seconds. So you have to hit the buzzers quick on this particular session that we're doing today. So this may or may not work. We may never do this again, but we're going to try it. Everything is current as of today. This session is being recorded, so you can watch it later. You can't take the test while you record it later, or watch the recording later, but you can watch this later. So this is I should have changed the slide, post-it test. This is, you've already sat through 5 or 6 webinars on billing over the last 2 weeks. So now we're going to see if you listened. So Paige, here's your first poll question. If you'll open it up, billing and coding are the same thing. We should be able to get that one pretty quickly because I think we've had this one before. But sometimes it's not that intuitive. Okay, Paige, you want to close that poll out real quick and see what we got? Okay, and what are the results there? So we know.
Oh, can you not see them? Oh, we got 100% that said B, false.
Very good, very good. You guys have been paying attention. Billing and coding are not the same thing. Coding is the creator is AMA, the American Medical Association. Those are your CPT codes. For billing purposes, a lot of times, not all, but a lot of times you do have to convert over into a HCPCS code, and that's what CMS, that's what the insurance companies, they may have their own HCPCS codes that they use for their particular billing, but coding is coding, and it will remain the same all over the country because it is based upon those AMA CPT coding guidelines. So that's an important distinguishment. Typically, you have to crosswalk certain services from the CPT code to the HCPCS code. A good example is Medicaid. In a lot of states, there's what's called a T1015 code, which is what you use to bill Medicaid in that particular state. You're going to crosswalk a 99213, which is on the QVL, to the T1015 and bill that to Medicaid. So Other services like a telehealth visit, that's going to crosswalk over to a G2025. In some cases, if it's a mental health visit, it's going to crosswalk over into the actual same code. You just have to add the CG modifier. So knowing that difference between billing and coding is going to make a world of difference on how that you bill. And a lot of people that are professional coders say, well, we can't bill that to Medicare insurance company because that's not the proper code. And unfortunately, they have a different opinion of that. They said, if you want to get paid for this service, this particular CPT code, this is how we want you to bill it to us. So causes a lot of issues. Paige, will you run this poll for us? Rural health clinic status directly impacts payments from the following. And when I say Medicare, I'm talking about original Medicare. I'm not talking about Medicare Advantage, because Medicare Advantage is just like a commercial insurance company. They typically have their own rules, and so they play by, like I said, they play in their own sandbox, and you have to play in it. Paige, what do we get for this one?
We got 66 or 64% of everybody voted, and 86% said D, Medicare, Medicaid, and then another 6% said A, Medicare.
Okay, yeah, it is Medicare and Medicaid. D is the correct answer the way I see it. So that is the way. So that is the proper. So most of you guys were paying attention there. 86%. We're doing good. RHC, and here's RHC status affects reimbursement from original Medicare for Medicaid. Medicaid is required to pay you a higher rate. There's something called BIPA 2000 that requires that. And if you're in one of those states that doesn't pay you appropriately, you should look into that. Georgia's a big offender of BIPA 2000. If anybody ever wanted to sue them, you would win. So hire your attorney, sue Georgia, Medicaid. They do not pay rural health clinics correctly. And I've been saying that for years and years. So most Medicare Advantage plans do not recognize RHC status. Do reach out to them. About 1 out of maybe every 10, maybe 2 out of every 10 will recognize the status and will pay you your all-inclusive rate. Now that your all-inclusive rates have increased dramatically over what they were before, original Medicare rural health clinic is better than Medicare Advantage as far as payment in most cases. So you'll want to do that. And then we talk about payment there, the golden rule. He who has the gold makes the rules. You want to charge everybody the same, but you want to bill in accordance with the payer's rules. And that's one reason why when people ask questions about how do we bill such and such insurance company, you really just have to generate a cheat sheet for, use what's called the Pareto principle. Take the 20% of your insurance companies that create 80% of the claims and make yourself a cheat sheet for those 5 or 10 insurance companies, so you know how to bill them. And then the other ones, the outliers, you can sort of work on those on an ad hoc basis. And here's one of the big differences is original Medicare for rural health clinic, we don't use 25 as a modifier typically. It's very, very rare. 25 or a 59 is extremely rare, but your insurance companies do. So this is a 1500 form. This is the way they're billed. And you see that modifier 25, that is required for a commercial visit, while same service billed to Medicare on a UBO4, which is your required format for a rural health. I'm giving away questions here, so listen in. So in this case here, same service, we're billed with a 99215, but we have to add the CG modifier. Do not put the 25 modifier on there. Bill claim on a UBO4 for rural health clinic Medicare. For commercial insurances, typically it's going to be on a 1500 form, and you're going to use the 25 modifier on a lot of those claims. Incident 2 question: if the service is not on an eligible QVL list, then what? And the QVL is the qualified visit list. And we'll have a question on that coming up soon. If you do have a service that's not on there, then you could possibly bill it Incident 2. Incident 2 services are within a medically reasonable time frame, typically within 30 days of an office visit. You can put that on a claim, and it will increase your copays and deductibles from the patient, but it will not increase the payment that you get from Medicare. Those are called Incident to services. So question number 3, Paige, if you'll open up that poll, please. RHCs bill Medicare RHC claims for RHC covered services using which claim form? And I probably got ahead of myself on those last questions there. So if you were listening and you hadn't passed out yet, you'll be able to know what the right answer is. Paige, do we get some answers in yet?
Yes. I went ahead and closed it because most everybody had voted, and everybody voted B, UB04.
Yay, you guys are listening. I'm so proud of you. Here is the format that you use. You bill on a CMS 1450. It's institutional. It's 837 institutional. It's called an ANSI format. And then this is a fact sheet from Medicare on how to set that up. So you'll want to make sure that when you're working with the Athenas and the Zelias of the world, that they know that you have to bill on a UB04 and get the proper formatting, the proper clearinghouses working with them as well. Here's the National Uniform Billing Committee NUBC codes as well. So these are the things that you'll be using. These are mainly used for Medicare Secondary, all of these different codes, condition codes, occurrence code, span codes, value codes, those things there, those what those are from. And in here, if you need to get a hold of them, if you get a reason code for a denial and need to look it up and you've never seen it before, this is a place where you can find those reason codes as well. I think you have to have a subscription to this. It's like $200 a year, something like that. But that you do need that for your billing to look up those reason codes. And then here is the 1500. Rural health clinics will be billing services on a 1500. Here's your formats to set those up. That's CMS 1500. It's got an ANSI 837P. P stands for professional. I stands for institution. A rural health clinic is an institution under rural health clinic rules. Also, rural health clinics are the money. It's a Part B service, even though it's paid for through a Part B trust fund. It actually comes from the Medicare Part B trust fund. You have to have Medicare Part B to get RHC services, but it is not a Part A. It is actually the services you provide in a rural health clinic do not come from the Part A trust fund. So I think we had a question about, some of our consultants this morning had a question about that, and we were all a little bit confused on that one. So RHC should charge here, Paige, if you'll open this one up, should you charge only the RHC reimbursement rate to Medicare and Medicaid? B, all payers using the same charge master. C, all payers the same charge master except indigent patients. Or D, just using a sliding fee schedule. And Paige, do you have an answer on this one yet? Or do you have to close it out?
We've still got votes coming in, but 93% are saying B, all payers using the same charge master. We've got 3% with A and another 3% with C.
Okay. Yes.
I'll go ahead and close it.
The correct answer is all payers using the same charge master is what you should charge. There is one exception to this, is that some of the people may have picked A, is for Medicaid. In some states it uses that T1015 code. They will require you to use your rate when you submit it to Medicare. So if your rate's 126, then you're going to put your charge at 126 in some states, not all of them, but just remember for Medicaid, and that's perfectly acceptable for you to do that. The state, again, that's the golden rule. They say they want you to put that rate on there, you put that rate on there for you to get paid. But for the most part, everybody should start with the same charge. Even if the indigent patient, even if poor old Mark Lynn, who doesn't have a dime to his name, comes in, you're going to charge me the same and then make me fill out these forms and say that I'm indigent. I live in a van down by the river with my 10 kids. I'm not going to be able to pay you very much money. And then you can move the charge, you can collect less than what the actual charge is, and then write off that difference as indigent. And again, we recommend people doing that. Get that sliding fee schedule set up so you can join National Health Service Corps and be eligible for loan repayment for your providers, because they're flush with money. You will get funded if you do that. So, and they'll pay $25,000 of tax-free loan repayment for the first 2 years, and then $20,000 a year for up to the next 16 years. So you could get $400,000 of loan repayment. I'm a person with a child in PA school. Believe me, we need loan repayment because it will help us. So there we go. Here's a charge example. The best way, and Charles did a great job of talking about what the charge. Look at your local fee schedule from your MAC. See what this non-facility amount is, and then multiply that by 150%, 200%. And I think, and Charles made a good point, is for your E&M codes, you probably want to keep that on the low end, maybe 150 to 175% of what Medicare allows. And then for anything else, maybe 200% of what Medicare allows is a good rule of thumb. So I think that was good. That's something I hadn't really thought about until Charles said that yesterday. There's the loan repayment information that we talked about just a few minutes ago. You'll definitely want to try to do that. Okay, Paige, our next one. RHCs are paid an all-inclusive rate which pays for all Medicare services provided to the patient while at the RHC. So this is an all-inclusive rate. Is that a hint? All-inclusive. I'm sure that's, okay, Paige, do we get our answers in?
Yes, so we've got about 70% of people have voted. We're actually kind of neck and neck. 44% say A, true, and 56% say B, false.
And it's 56% is false. And the reason is the terminology is very confusing because it says all-inclusive rate. It's not all-inclusive. It's only for certain RHC services. There's services that are performed in a rural health clinic that are not covered under the RHC that are very typical. Things like your lab test, all lab tests, including the 6 required tests to be a rural health clinic, are not covered under the RHC benefit. Now, don't ask me to make this logical for you because I can't. But you can bill that fee for service on the 1500 form and get paid for that. Same thing with your technical components. You're going to bill that to Medicare Part B and get paid fee for service for that. So those are some of the things that would not be covered under that all-inclusive rate. Also, hospital visits are not included as an RHC service as well. So very good. That one was confusing. I'm glad we went over that one because we had a lot of folks that didn't quite get that answer. So here's the all-inclusive rate does not cover the following. Again, lab, technical components, hospital services. Telehealth, that's billed for E&M services. That's billed on a fee for service. It's billed on a UBO4, but it is paid fee for service. Your chronic care management, same thing. Principal care management, same thing. And there's a whole list of different services next year. Look at that presentation that Nathan and Sarah did on Monday. There's a lot of things that Medicare is going to start paying for in 2024. And so look at that list because there's services you can provide that are necessary that will help your patients and you'll get paid for it. So that's a good thing. Mental health services, those, if you do those via telehealth, you will get your all-inclusive rate, and that is an allowable expense on the cost report. So keep that in mind. And then here are all the different types of services. Here's what will typically be billed on the UBO4. Here's what's going to be billed on the 1500. And then there are some services that you just don't bill at all. They're put on the cost report. So things like influenza, pneumococcal, COVID-19 vaccines, those things pass through on the cost report and you'll get paid additional money on your cost report. So keep that in mind. Okay. Number 6 here, there's going to be math involved in this one. So Paige, just give them a few more minutes on this one, or not a few minutes, a few more seconds on this one. How much will Medicare pay of the RHC for a 99214 with a charge of $200 if the clinic has an all-inclusive rate of 126, which is the national statutory limit for 2023. We're going to get paid $200, which is our charge. We're going to get paid 120, 126, 99, or 139. Okay, Paige, we've given them a little bit of time to do a little bit of math. What have we got for our answers?
Okay, we've got about half of our attendees have responded. We've got 60% that say $99, so C, and then we got 35% that say 126, or 36%, and then we got 4% that say D, 139.
Okay, what were the answers again? How many said 99?
60% said C,
60% said 99, and then another 30 or 40% said 126, basically?
126, yep, and then we had a couple that said 139.
Yep. The correct answer is 99. 99 is the right answer. And here's what Medicare pay. Again, remember, this is a Medicare Part B service that you're providing. So there's a 20% co-insurance payment with Medicare Part B. So right from the very beginning, Medicare cuts off 20% because that's going to come from the patient. Then there's a 2% sequestration because Obama and Bonner 11 years ago could not agree. And we had one of those budget stalemate things that we tend to run into about every few months nowadays. And the way they paid for a budget difference there was they have a 2% sequestration where they reduce payments by 2%. So we get 78.4% of our all-inclusive rate. So that's all that Medicare is going to pay you for that. Remember, our charge was $200. So there is a $40. So in this case here, if you take 20% times 200, there's a $40 copay. There are no limiting charges in rural health clinic versus if you're billing the Medicare Part B, there's something called limiting charges that says with Mark Lynn, this old Medicare patient that I am, I come in and, you know, I go to a Medicare Part B physician, they can only charge me $14.75 for a 99213. There's a limit that shows for every provider has in their locality. And so you're limited to that. Rural health clinic does not have that. So your patients will pay a higher copay in general as a rural health clinic. So here's how you would post this payment. We charge $200. We collected $40 from the patient for the copay. Our interim rate was $126. We had a 2% sequestration, and we collected $99 from Medicare. So when we first have the patient comes in, we're going to credit our accounts receivable for $200, and we're going to debit $200 as a receivable from that patient. When our payment rolls in, we're going to have from Medicare, we're going to have a $99 cash collection. We're going to write off $61, and we're going to post $160 as a credit to accounts receivable. And so now we'll have a $40 copay lift. Your remittance advice should show what the patient responsibility is. And anytime you're posting, you want to post to make sure that you actually agree with what the patient owes, either in copays or co-insurance. That's your important checkpoint. And then write off any underpayment or overpayment. It could be an overpayment to contractual adjustment. There's no lesser cost of charges in rural health clinics. So if your charge is only $100 and you collect $131 in total, it's actually perfectly fine. You can collect that, and you can actually have a negative contractual adjustment in rural health clinics. So it's very weird. You'll get a lot of strange looks from your patients when they get their Medicare summary notice, and you may get a few angry phone calls. But you can do that. Okay, number 7. To bill Medicare RHCs must always have a face-to-face encounter. And true or false? And these are pretty easy at this point, but some of the ones at the very end are going to be a little bit harder. I'm going to go over the stuff that Nathan and Sarah talked about on Monday, and so they'll get harder as we go along. So don't think this is going to be an easy one. Okay, Paige, what we got?
Yeah, we got 48% is almost 50-50 with true and false. So we
Okay.
got 48% that say true, 52% that say false.
And the falses are correct, but to bill Medicare, RHCs must always have the face-to-face encounter. That is not true. There are services that are out there that you do not have to have a face-to-face encounter to bill. Things like telehealth services, that you're not having a face-to-face encounter there. Chronic care management, that 20 minutes of time that you can do every month for a patient with two chronic illnesses, or principal care management if they have one, you can do that. That's the G0511. Now you can use that for remote monitoring of a patient. If they have heart failure, you can monitor them remotely and watch their heart rates with that. Principal care management, you can do that. And there's, like I said, there's a whole list of things, and you can bill it more than once in 2024. Used to, in 2023, you just had one per month. You can also, you can bill your primary care, you can bill chronic care management for two conditions, and maybe you have a cardiologist who's taking care of the patient's heart failure. They can also bill principal care management because they're being specific for the care of that particular diagnosis. So the rules have changed in 2024. So you want to watch these rules. There's a revenue stream that's out there that was not there before, and it's going to help you provide good patient care. So again, used to tell me no margin, no mission. You want to find out what these revenue streams are so that you can better serve your patients and take care of their health, because that's important. Okay. And then here's the example in chapter 13 of what a face-to-face encounter is for you. I'm not going to read that to you. You've probably seen it by now. Here are the requirements to bill a face-to-face encounter. Must be an MD, DO, nurse practitioner, PA, certified social worker, or clinical psychologist. And next year, they're adding a marriage therapist and family therapist. There's a whole list that Nathan and Sarah went through yesterday or on Monday of what is now as a part of face-to-face encounters, and you're eligible to get your all-inclusive rate for those particular providers as well. So you want to look into that for 2024. Put that on your to-do list. Must be medically necessary. Must be within the scope of practice for the provider. Must require the skill of that provider. You just can't have your physicians walking into rooms and saying, "Hi, Mark, how you doing?" and then have the nurse do everything else and you not do anything. That's going to get you in big trouble. And it should be on the QVL as well. It should be. Now, it doesn't have to be on there, because the QVL, and I'm going to give away an answer. I'll shut up there. We'll talk about that answer in a minute. There we go. I knew I was getting up to it. Okay. For a RHC to bill an encounter to Medicare and receive the all-inclusive rate, the encounter must be located on the published QVL listing. Okay, I came very close to giving that one away. Hopefully, if you're listening, you're going to know what the answer is to this one. Okay, Paige, what did we get?
We've got about half of folks have responded. 37 or 35% say true, 66 say false, 34 say true, okay. 64 false.
And the falses are correct again because it says published QVL list, and that's the last published QVL list was in 2016, 8/1/2016. They've added to it since then. They just haven't told us. And so this is not the gospel. It's not all inclusive. That I think it's 11, 12, 13 pages of QVL of CPT codes is not all inclusive. So if you think something should be billed, I would recommend billing it to Medicare and crossing your fingers and hope that it gets paid. Make sure that you can meet that criteria that I showed you earlier about medically necessary, face-to-face encounter, all those sort of things. But yeah, it's not been updated. I don't know why they have a place where they put it, where they update it on the internet. I have never found it. I think Patty Harper has found it a few times and told me about it, but I've never found it. Next question, Paige. An RHC must include a CG modifier on all claims for RHC covered services. Okay, and I'll give you a little hint on these questions. When I say all, and you deal with the government, there's never anything that's all with the government because they throw you a curve or make an exception and just mess up every system that we have for this. So, Paige, we'll get all our answers in.
Yeah, we got most of them in with 33% saying A true and 67% saying B false.
Okay, the falses are correct again. You don't have to put a CG modifier on everything. The difference is that the IPPE is not required. If you build that particular service, you do not have to put a CG modifier on it. That is, I think there may be one other exception to it. I don't remember off the top of my head right now. Do remember preventive services, they do not have any copays or any deductibles on those. If they're a grade, I think it's grade A or B on the United States Preventive Task Force on Preventive Services. If it grades that out as being effective, then there's going to be no copay or deductible. There's a few preventive services that you can provide that they actually do have to pay a copay or deductible because they haven't proven to be as effective as the ones on the list that were not. So, okay. This one will be very controversial too. The Medicare Secondary Payor questionnaire questions must be asked A, every visit, B, annually, or C, every 90 days. Okay, and you're probably not going to like my answer to this one. Okay, Paige, how are we doing?
We've got most everybody answering A, every visit. We've got a couple that said B, annually, and a couple that said C, every 90 days, but most said annually.
Okay, so every visit is the one that is correct. If you look up the Medicare Secondary Payor rules, if you just Google Medicare fact sheet, you will see a nice, beautiful, like 20-page fact sheet with nice, pretty pictures that are easy to understand. Keep that by your desk if you're a biller because you'll need to refer to it because they have all these little tables on it. But it does require you to try to get this information every single visit. Now it's pretty much impractical. You're supposed to have a hard copy and keep this information for 10 years, but you definitely, every time a patient comes up there that's a Medicare patient, you'll want to ask them just a list of questions there, and you should have it some way in your computer system to where you can just click off the little boxes that said, I asked Mark Lynn, whether this was by an accident, if he has black lung, if it was due to, does he have Farm Bureau? Does he have an employer with over 100 employees or 25 employees, or all the list of those 8 questions? You'll need to just give a courtesy effort there. Basically, if Mark Lynn or Mrs. Jones comes in and you have an orthopedic injury, then you'll want to get a hard copy of that so that we can figure out if Farm Bureau or State Farm or Walmart is going to pay for whatever that injury is. That orthopedic, if you broke your arm, they'll have somebody else to pay for it. So, and Medicare saves about $10 billion a year by doing this. So Medicare Secondary Payor rules are important. And then here is what you should do. They give you the list of what you should do. Here, incorporate your MSP questions on eligibility verification. Basically, those are the rules that you have to meet for Medicare Secondary Payor. And hang on to this one, show it to your people because nobody likes this, but that's the rules. And then here's all the different MSP situations there. You can see how pretty they make these little tables and stuff. I like those. And then here's the actual questionnaire. It's like 16 pages long. What you can do is make a 1-pager that works just fine. You don't have to print out all 16 pages for them and keep it for 10 years. Again, sort of ridiculous. I think there is a group of guys that live on the ocean at New Jersey. They've got this nice little condo and they make all their money by getting a percentage of people that don't do MSP correctly. Hospitals and clinics, if you don't do it correctly, these guys come in, audit you, give it to the government, and the government gives them 35% of the money they recruit because you didn't do it correctly. So there have been big payouts, and so you want to be careful with that. Okay, Paige, CPT Category 2 codes cannot be included on the UB04. True or false? And this is another annoying thing about rural health clinics because we need to get this one fixed. Okay, Paige, I've probably given it away with my comments, but go ahead and give us the answers.
We got 72% that say true, 28% that say false.
Okay, so 72% trues are correct. You cannot put CPT Category 2 codes on the UB04. That is a big problem for rural health clinics, especially as we come into a value-based payment world. We can't get our value codes into Medicare, especially these things about annual wellness exams and IPPEs and all those things that score tons of points for your value. We have a hard time getting those in there, so we want to. That's, I think, from a legislative standpoint, we want to take a look at that. Here's Patty had done something about Category 2 codes. Here, some Medicaid programs, you can put those on a 1500 form. I've heard of some people billing Medicare on a 1500 form and putting a penny on it as well. And I've heard some people say it works, some people say it doesn't. So I get mixed results on that. But you can get a registry and report that to CMS through a third party as well. So here's Patty's information. If you want to figure out how to do that, that would be great. Place of service code. Paige, if you'll put this one up, what place of service code should an RHC be used when billing Medicare? A 72, 11, or the revenue code serves as the place of service on a UB04? Okay, Paige, we got our results yet?
Yep, so most everybody's voted. We've got 29, 27, we got about 30% that say A, 72, another about 10% that say B, 11, and then the rest, the majority, is saying C, revenue code services, place of service code.
That's correct, that's correct. You bill on a UB04 as a rural health clinic services, and there's no place for a place of service code on a UB04. There's revenue code, so typically it's going to be a 0521 will be for an office visit. That will be the one you'll probably use 99% of the time. The 11 and the 72, those are billed on 1500 forms. Most times for Medicare claims, you're going to bill 11 because you're doing it in basically a physician service, in a physician service area when you do it in the rural health clinic. And then for Medicaid, depending on who your MCO is, depending on which state you're in, most of the time they require you use a place of service 72 for billing Medicaid on the 1500. So remember the golden rule. Who has the gold makes the rules, and whether you get 11 or 72 to Medicaid. But for Medicare, there is no place of service for that. So let's go next one, and then here's the revenue codes. This is from Chapter 9. This is one of our Bibles. Chapter 13 and Chapter 9 are your billing Bibles. You can look up the information there in Chapter 13 or Chapter 9. Okay, this is going to be fun. There's going to be math involved in this one. RHC treats a patient on January 1, 2023, charges $226, must be like a 99214. The RHC all-inclusive rate is $126. When the bill is submitted to Medicare, how much does a rural health clinic get paid? Is it A, $0, B, $100, C, -$100, or D, $25.20? Okay, and since there was math involved, I'll give you a few more seconds. Okay, Paige, what'd you get?
We've got 14% that say A, 0, 3% that say B, 100, 76% that say -100, and then 3% that say D, 2520.
Wow, that was actually better than I thought y'all would do, because the correct answer is C, -100. That's called negative reimbursement, and it is horrible, but it's what happens. Is at the beginning of the year we bill $226 for our first visit of the year. Our all-inclusive rate is $126. That $226 is applied to the deductible for this year. That means that you should be collecting $226 from the patient, which is the beneficiary responsibility, Medicare says, hey, you collected $226 from Mark, but your all-inclusive rate was only $126, so you over-collected that. So we want to take that $100 away from the next patient that comes in. So that's called negative reimbursement. That happens every January, February. There's a lot of negative reimbursement. I'm not saying this is right, but some people just hold their claims until March or April, and then they let the cardiologist and the specialist eat those deductibles, so they don't have to eat those. Again, I'm not saying that's right, but I'm just telling you that's what some people do. But that's what happens. It's called negative reimbursement. Okay, and then let me see here. Are we really this far along? Okay, 14. When posting negative reimbursement claim, an RHC should always A, ensure that the patient balance remains correct after posting. B, post the withhold to the patient balance. C, include the negative reimbursement on the credit balance report. Okay, and how we doing, Paige? What's our?
We've got 75% that say A, about 11% that say B, and the rest say C.
Okay, and A is the correct answer. Just make sure this doesn't have anything to do with the patient, that negative $100 that they took away from you. If it says on there that the patient owes you $226 for that deductible, that's what you collect from them. You don't collect an extra $100 because you got a negative number as well. So $226 is what you collect from the patient. So, and then here's how you would post that. The first day when you charges were $226, so your sales were $226. Your patient receivable was $226. Once we get the Medicare remittance advice back and they basically took $100 away from us, all we're going to do is we're going to debit contractual adjustments, meaning that we're not going to get paid that, and we're going to credit cash because we didn't get that money in our bank account like we thought we were going to, and we're just going to credit cash or payable for that amount. So keep that in mind. That's the way you're going to code that. Okay, next question. An RHC patient receives an EKG. How is that billed? And A, code 93000, that's a global, to Part B on the 1500 and get paid fee for service. B, CPT code 3000 on a UBO4 as an RHC service. Or C, bill 9305 to Part B and 93010, it's going to go on the UBO4. Or D, we're going to put it on the cost report and get paid for it at the end of the year. Paige, what are our answers on this one?
Yep. Okay, so we've got 4% that say A, 8% that say B, majority with 83% say C, and another 4% say D.
Okay, C's have it. It is right. You're gonna one rule that you want to think about is there's no globals in a rural health clinic. So anytime you see a global code, do not bill it as an RHC. Also, I used to say there's no groups in rural health clinics. And so as of up until this point, there's been no groups that are paid in rural health clinics. Next year, there's a new service called IOP, intensive outpatient, intensive outpatient program. And there's going to be groups in that. That's a part of that. If you do 3 groups per day, then, or I think it's up to 3 groups per day, you're going to get $284 in that IOP. You'll be able to do groups next year. Getting back to this question here, though, still no globals, and you're going to bill the 9305 to Medicare Part B if you're an independent RHC, you're going to bill on the 1500. If you're a provider-based, you'd bill it on the UBO4, and so you would get paid fee for service for that. If you're a CA, you're going to get paid cost for it. Use a bill type 851 for that. So C is your right answer. And then here is just a table showing you how to do that as well. So we won't do that. Remember, technical components, you're going to get paid $7, $8 fee for service for that. The interpretation is going to be an incident to service. You're not going to get paid anything for it, but your co-insurance will increase because of that. Okay, and then radiology, you're going to do exactly the same thing. If you do a chest x-ray, The technical component will be going to Medicare Part B. You'll get paid fee for service. The professional piece will get paid incident to. The way I look at it, or a little helpful thing in your mind is if you used a machine to do it, that is a technical component, and you can bill that to Medicare Part B and get paid fee for service. Or if you're a hospital, you can bill it and get paid a fee or cost if you're a CA. If you use your brain to do it, that's going to be a rural health clinic service, and that's going to go on the UB04. And if it's not a visit involved in it, then it's going to be an incident to service. So brain, UB04, RHC service, machine, technical component, fee for service, not an RHC service. So that's how I keep it in my brain, how it works. Okay. How many CPT code G0447s can be billed annually per patient? 12, 22, 24, or as many as medically necessary? Okay, and
we've got most people responding, well, it's kind of neck and neck on A and B. 51% A, 41% B, 2% C, and 5% D.
Okay. Yeah, I must have gotten the wrong version of this presentation too, because I looked at this and I was like, okay, the correct answer is 22. When you look at the preventive services there, it tells you very clearly on there. It says G0447, you can bill up to 22 of those per year. I should have, when I edited this morning, I removed this as many as medically necessary because I thought that would be confusing to you, and I just put a random number on there. So 22 is your number there, and basically you can get, I think it's one a week for the first maybe 2 months of G0447s, and then after that it's like one a month, and then it just stretches out to where. But if they're on a weight loss program with you, they can get up to 22 visits per year. It's also paid at the all-inclusive rate with no deductible and copay. So you're going to get, next year, you get $139 for every time that Mark comes in and you tell him, Mark, no more hot fudge cakes. You know, you can, there's a certain amount of time you have to do consulting with them, but that is a great way to really, especially now that everybody's got this semaglutide and all that sort of stuff. Working with your patients, that is a good way to get that started. You're not going to be able to cover the cost of semaglutide because it costs so much through the thing, but write them a script for it, have them fill it, and then have them come in and work with them, because as soon as they go off that semaglutide, they're going to gain the weight right back. So give them some tools to keep that weight off. So okay. Here's what it looks like when you go on the website for Medicare. Up to 22 visits per year for weight loss paid at the AIRs. It's one of the first things that you'll see on there. Face-to-face and counseling is 15-minute sessions, so it will take a little bit of time to do that. Remember, that's not necessarily completely face-to-face time with the patient anymore. That they're preparing, if you're looking at the chart before, anything done on that day of service towards that patient will count towards that 15 minutes. So keep that in mind. Okay, here is this table here. It's really neat because if you click here, you'll go and you'll see the screen right here. And then if you click on any of these, it's going to tell you exactly how to do it. It's going to tell you the ICD-10 codes. It's going to tell you what you have to do to meet the criteria to get paid for this. So if you've got providers that are not busy, this will help you keep them busy. Just say, okay, Mark, you're the slowest provider we have. You're seeing 3 visits a day. We're going to sign you up for a bunch of preventive services for our patients, and we're going to get them in and get this done. So that will be a great way to use this tool to help your practice generate revenue. There is a table. It's about 3 pages long for preventive services on here. So you can go here, look at this table, and see how they pay you. So let's take a look here. We're getting down to the very end here. Okay, we're almost right on time. A patient receives an annual wellness exam and an E&M exam on the same day. How is it billed and paid? And Paige has this open. An AWE is billed fee for service on the 1500, and the E&M is billed on the UB04. That's A. B is an annual wellness and an E&M is billed on the UBO4 and only one all-inclusive rate is paid. C, the annual wellness and E&M are both something, I can't read that, let me see here, maybe that, okay. A&W are billed on the UBO and 2 AIRs are paid. And then both are billed to Medicare Part B on a 1500 and are paid as long as you use a modifier 25. So Paige, what were our answers on this one?
We've got 2% with A, 82% B, 13% C, and 3% D.
Y'all are very smart. The answer is B. You only get one of these, one pay for a annual wellness exam. So, and that's different than Medicare fee for service. You typically would get paid for both of those. As a rural health clinic, you're going to get only one of those, and don't intentionally. I think if you listen to Charles yesterday, Charles got in trouble yesterday for saying have the patient come back the next day and get their annual wellness exam after an E&M. The CMS person who we know and love, Charles and I both have experiences with her, and we both love her. She's sweet as she could be, but she would get you in trouble. She would get me in trouble every once in a while. Well, if I said the wrong thing, she'd come up and tell everybody, Mark, you're wrong. So it was quite embarrassing. But annual wellness exam, you only get paid one of those. Let's go to the next question here. If it was an IPPE, there's an exception. If it's an IPPE and an E&M, you'll get both of those paid. So that's, again, everything is confusing as far as rural health clinics goes because there's always an exception to every rule. And the one that, let me go back a little bit here. I'm gonna go back. Here's on this preventive services chart, you can see here, IPPE, it says it's paid at the AR, it's eligible for same-day billing. This is the only preventive service that's eligible for same-day billing. So keep that in mind. Okay, and now let's go 18. These are gonna get harder. I'm gonna have to look at my answer sheet here. The physician treats an E&M telehealth patient from his home after hours. How is this billed and paid by Medicare? A, bill on the UBO4 to Medicare Part A with a G2025 CPT code, which pays $95.37 in 2024. B, bill on the 1500 Part B with a 95 modifier and be paid fee for service for the service. C, after hours telehealth cannot be billed at all. D, after hours telehealth cannot be billed but can be included as an allowable expense on the cost report. And this stuff is brand new from Nathan's webinar on Monday. I think I owe Nathan an email from one of our clients to see ways to do this. So this answer may not be the answer in stone. It may change as we go along. But as of right now, the way I read what Nathan told us on Monday, this is the way I would answer this question at this moment. Okay, Paige, did we get the answers?
Yep, we got 38% that say A, 33% say B, 16% say C, and 12% say D.
Y'all were just as confused about this as I am, which is that's good to know. At least I'm in good company with you. The answer that I believe, as of the moment, is B. You can bill it on the 1500 to Part B with a 95 modifier and be paid fee for service. That is the way I understood it from the other day. We're going to keep on getting more and more clarification on that as we go along. But the way the CMS said it was you could not, an RHC could not provide telehealth services in non-rural health clinic hours. So if that's the case, then we're left with the option of billing on 1500 Medicare Part B. We're going to exclude that cost from the cost report no matter what, even if it is a telehealth service. So that's the way I looked at it. Okay, now here's the next one, and we only have one more question after this one, so we're going to be right on time. The physician treats a medical health. It should be mental health. A mental health patient. No, wait a minute. Let me see medical. Let me make sure. Okay, yep. This should say mental. Okay, so a physician treats a mental health patient from an RHC during RHC hours, audio visual. How is this billed and paid by Medicare? Okay, and A, bill on the UB04 to Medicare Part A with a 9XXXX CPT code and a CG and modifier 95, and that's optional, which pays the all-inclusive rate and is an allowable cost on the cost report. B, bill on the 1500 to Part B with a 95 modifier and be paid fee for service, and the cost will be excluded from the cost report. C, bill on the UB04 to Medicare Part A with a G2025 code, which will pay $95.37 in 2024. And D, bill on the UB04 to Part A with a 9XXX CPT code and CG modifier, and it's not an allowable cost on the cost report. So Paige, what? That was a mouthful. What did we get for the answers for this one?
We got 41% say A, 2% B, 52%, so the majority say C, and then 4% say D.
The correct answer is A. You want to bill on the UB04. You want to use either that 90X CPT code or the 9921 whatever code. You're going to use a revenue code 900 for mental health services. You're gonna have to put the CG modifier on there. You don't have to put the modifier 95 on there. I would recommend putting it on there. And it is an allowable cost on the cost report because you are getting your all-inclusive rate for mental. And I apologize, I'll go back and fix this slide. It should say mental health patient, not medical health patient. So I'll fix that. Let me see here. And you will be getting the slides. I'll fix the slides and send those out to you. So I'll send the right version out to you. And you do have the questions as well, the test as well. So let's go. Last question. Hallelujah. Paige, you've done great on getting us through this. So number 20, how often does an RHC have to complete the Form 838 credit balance report? Once a week, once a month, once a quarter, or annually? And this is important. If you don't do this on time, what happens is you're going to call me up and say, Mark, you sorry dog, you didn't do our cost report, and now our payments have been cut off thanks to you. Y'all are usually nicer than that, but that's typically, I'll get these phone calls about every so often. So Paige, give me the answers to this one.
Okay, we've got 89% that say quarterly, 11% say annually.
Quarterly is the correct one. So 90% of you guys have had that happen. If you do not do this, this form, you will not get paid. They will cut off your payment so fast. So once a quarter, what you want to do is fax this into your MAC. Make sure you get the right MAC. Make sure you get the right contract. A lot of contracts like Palmetto, they have a JJ contract, a JM contract, and Novitas has HH contract and HI contract. I mean, they have different contracts. So make sure you get the right fax number, and you can fax this in. You can send it in electronically to them. But once a quarter, fill out this credit balance report and submit it to Medicare, and that should be done. Okay, so we are finished with the test. I think the majority of you guys did really, really well on this. Y'all been listening to these 6 presentations that we've had, and you've learned a lot. Apparently, some of this stuff is new. And do we have any questions on here? Paige, do you see any questions? I'm actually not seeing any questions.
I don't see any questions. I don't see anything in the chat.
Okay, well, good. Well, that is a miracle. I was expecting all sorts of super hard questions. So perfect. Well, we're right on time. It's 1:59 Eastern time. So thank you, everybody, for participating today. We'll get these resources out to you. Remember, they're going to be on our website at ruralhealthclinic.com as well. So if you don't see it in your email, you will see it on there. I'll put the link on there for it. Thank y'all. Y'all have a great holiday season. Merry Christmas. I know that Trent and Paige and Danny and myself will be probably taking some vacation time. And so we'll be a little bit tougher to get a hold of, but we will get a hold of you, or just get a hold of us when you can, and we'll be glad to work with you any way we can. Thank you very much. Bye, everybody.